All right, I'm happy to introduce our last speaker for today, Dr. Larry Leichman, who is going to talk to us about the progress in therapy of advanced pancreatic cancer. Dr. Leichman is a professor in the Department of Medicine, Hematology, and Medical Oncology.
Thank you, Rachel. Number one, thanks for inviting me, and number two, thanks for keeping the room so cold. So these people are awake. Some of them have earmuffs. Some of them are already sniffling. I don't think any bacteria, Dr. An, can live in this room, but I'm appreciative. Number two, it's interesting. The most fun talks for me are listening. I missed Dr. Gross's talk, but I've been here before, so I'm not my first rodeo with Dr. Gross. What you need to know about pancreas cancer at this institution is that it is not an individual play. It's a team approach in almost every direction. Almost no patient with pancreas cancer goes unconferenced. And what that means is that if I have a patient who may need an operation, we have a conference about that patient with surgeons, with medical oncologists, with gastroenterologists and pathologists, and we have a conference and we have a conference for patients who cannot have an operation to discuss their most appropriate therapy. There is nothing we do here in pancreas cancer that isn't essentially a team approach. And amazingly enough, although many patients don't go to surgery, the surgical advice we get every day, the advice we get from our GI medicine folks is invaluable. So this is a really cool place to work for me, and I've certainly enjoyed my time here. I am also the person I'm trying to get through this in about 15 minutes or so. I've got a few slides. I'm the person that tells you, if you can't handle this, turn off get the children out of the room, because I don't really have good news. I mean, I'm going to show you slides that are a little uncomfortable. And I brought this, I had about 85 or 90 slides, which I talked at Cornell University recently. I brought it down to about 30, 40. Thought maybe you'd like to stay all afternoon. But I didn't dumb this talk down. Ovarian cancer is a cancer we can treat. This is a cancer we can't treat. 6% of our patients have a 5-year survival. Dr. An glossed over that. I'm not allowed to gloss over that because these are my patients. She told you it was 93%, and it's about exactly right. We don't do well with this cancer. It stinks. What's frightening, and I suspect Dr. Gross mentioned this, was that there are 54,000 new cases in 2016. The average age of diagnosis, I apologize to my colleague Dr. Newman, I said it was 70, it's in fact 60 to 65. What's really frightening about this tumor is that by 2030, there will be 88,000 new cases. When I gave this lecture 15 years ago at the University of Southern California, there were indeed 30,000 new cases, maybe 25,000 new cases. This cancer is increasing and is frightening to us. And I would love to think that Dr. An is right, that we can prevent this cancer, because that is the only thing that's going to help us here. We are going to have 63,000 deaths. It'll be the second highest death rate should I live to 2030. It's not a good piece of business. Smoking, obesity, the environment, maybe the environment, as Dr. An just mentioned, that we bring to this cancer, our own environment, chronic pancreatitis, diabetes, family history, and genetic syndromes all account for risk factors of this cancer. Pancreas cancer has a unique molecular carcinogenesis. One gene is responsible, a gain in function, an oncogene called KRAS, is found in between 90 to 95% of our patients with pancreas cancer. And in fact, I would doubt that the patient has pancreas cancer if they don't have what we call a KRAS mutation. Now, this is good and bad. I mean, it's good because it gives us something to shoot at, and it's bad because we don't yet know how to shoot at the KRAS mutation. But one day we will, and we are already working on that, and there are people at NYU who are so-called, and they are indeed, KRAS mutation experts. CDKN2A is also found frequently, and the gene P53, which is known as it's the king of our our oncogenes and tumor repressive genes is found in quite a few patients. SMAD4s. I'm not going to do this in any detail, but there are patients that have a genetic syndrome. There's a patients that are susceptible to breast cancer, ovarian cancer, and these patients have what we call double-strand breaks and mutation, and these are called BRCA1 and BRCA2 patients. And we see these patients actually about 3 to 5% of the time, and they can be responsive to different types of chemotherapy. So we're aware of the genetic syndromes, and we're aware of KRAS, and we're trying to shoot at these specifically. Patients frequently ask me, how long did I have this cancer? And until recently, this really wasn't very well known, but there's some very nice mathematical modeling suggests, unfortunately, that it takes about 12 years from the earliest genetic alterations to the time that we might see something genetically to develop a cancer that Dr. Newman can operate on. This is not something that happens rapidly, but once it occurs, once we can see it, the mutations happen quickly and the tumor spreads quickly. So it's a question that maybe you weren't asking before you got into this room, but my patients ask it to me all the time. Cancer doctors, surgeons, oncologists, radiation oncologists need to stage cancers. I don't like staging pancreas cancer because I look at it as Dr. Newman looks at it, as you're either operable or you're not operable. You're either working to cure very hard or working to make sure that we make you live as long as possible comfortably. And quite frankly, I'm going to talk about adjuvant therapy and neoadjuvant therapy, and these are folks I plan to cure. Now, whether I do or not is another question, but I'm willing to make you a little bit sick to cure you. I'm not willing to take patients who cannot be operated on for cure and make them very sick. So if we look at stage 1A disease, which is about the earliest place we will find our patients, unfortunately, the median survival for all patients is only 2 years. This is the earliest. We go down to stage 2B, where I see most of my patients without any therapy afterwards. The median survival is only a year. So as I said, this is not a talk that makes you happy, and you might want to tune out and not let the children hear this. This is not good. If we take patients who come to us with stage 4 disease, the median survival back in 2007, now this is an old slide, thank goodness, was less than half a year. Where did these tumors go to? They go to the liver, they go to the peritoneal cavity, they go to bone, they go to lung, they go to any place in the body that they will find a home. About 20% of our patients indeed have local cancer. These are the patients we want to operate on. Unfortunately, many of these patients have what Dr. Newman showed you was basically stage 3 cancer patients that have tumors that are wrapped around vessels, and we cannot operate on those patients. So now I'm going to talk to you a little about chemotherapy, because that's what I do for a living. I give chemotherapy, and I do research also in pancreas cancer with Dr. Newman and others. And we take our research pretty seriously. Setting the bar in chemotherapy has been a disaster for medical oncology for one main reason, that we have a drug called gemcitabine, which was found to be effective in pancreas cancer in only about 12% of patients where we get a response rate, and showed a median overall survival of 5.5 months. And it was thought for years that we should be able to easily improve on gemcitabine, because this comes from a slide that I made up in 1996, 20 years ago. 5.5 months with gemcitabine. This is the structure of the drug. I'm sure you're terribly interested. And unfortunately, this is the bar that we have set for gemcitabine. It's a relatively low bar, not the high bar of the last jumper. The gemcitabine effect, in my world, set a bar so low that we constantly expect to exceed expectations. So if you were in my position for many, many years, you were just trying to find drugs that were better than gemcitabine. And for years, we put gemcitabine with a whole host of drugs and never found anything that was better. But we did create a great industry in gemcitabine. And from the years 1997 to 2011, we were stuck with that 5.5 median survivorship for patients with disseminated or stage 4 cancer. And then some very bright people in France put drugs together that we already had. There were no experimental drugs in this combination, and they called it, as the French would, FOLFIRINOX. And FOLFIRINOX is a combination of 3 drugs and a vitamin called leucovorin. And indeed, for the first time in my career, did we have a real combination of drugs that brought our median survival out to about 11 and a half months, practically a full year, for patients that have disseminated cancer. That's almost doubling the survival of gemcitabine, of the median survival of gemcitabine. And if you're in my practice, when we talk about median survivals, I have patients that have been on FOLFIRINOX now for over 2 or 3 years, and so do my colleagues. Unfortunately, there are still quite a few patients who are back in this part of the curve. Median, as you all know, is that halfway point, and it is very significant for us, and this was a major breakthrough. Unfortunately, FOLFIRINOX is very toxic. It is very difficult to give to people even my age. When you get over 65, it causes significant bone marrow toxicity, mucositis, diarrhea, and it can be tough. On the other hand, there are certain patients that do extremely well with it, and we've had a tremendous success with this combination. What's interesting is that just at about the same time that FOLFIRINOX had come around, a colleague of mine, Dan Van Hoff, talked a company called Celgene into testing a drug called nab-paclitaxel. This is a drug that's attached to albumin. It's called Abraxane. At least Celgene calls it Abraxane. It's easy to remember. And Dan found that if you combined nab-paclitaxel with gemcitabine, that the median survival versus gemcitabine was about 3.5 months more. And that was also statistically highly significant. Not quite the same as FOLFIRINOX, but much easier to give and much simpler to give, 2 drugs, and I can give it to patients practically at any age. So now, suddenly, in 2013, we have made some progress, and we have drugs that can keep people alive well over a year. And indeed, I don't know if many of you know what the words cross-resistant mean, but many chemotherapy agents, if I give one, I can't give another because the patient's already resistant to it. The lovely thing about the 2 combinations of gemcitabine and nab-paclitaxel versus FOLFIRINOX is that these are drugs that are not in the same category. And many patients who respond or don't respond to FOLFIRINOX will indeed respond to nab-paclitaxel and gemcitabine, and vice versa. And now, suddenly, we're seeing patients with disseminated pancreas cancer alive at 1.5 to 2 years at a regular basis, so that I become real close friends with these patients, and I'm no longer saying goodbye to all of them. And that's been a major breakthrough for us. It's not good enough. It simply isn't good enough. We need drugs that can cure patients. We need to find ways of curing folks. And this is where we work together with our surgeons and GI medicine people. Adjuvant therapy is treatment that's designed to augment a primary treatment such as surgery. Effective adjuvant therapies in breast, gastric, colon cancer, and rectal cancer actually increase the median survival by 1/3. So we augment in adjuvant therapy. After the operation, we give chemotherapy or chemotherapy and radiation and push the treatment, push the cure rate out. The goal of adjuvant therapy, as I said at the beginning of my little show, is cure. Effective adjuvant therapy in pancreas cancer increases the median survival by about 1/4. Is that terrific? Absolutely not. And indeed, I'm sorry, go back. Go back. How do I go back? No, wrong way.
It's okay, click anywhere on the screen.
Sorry, folks.
Okay.
Oh, that way. Okay, fine. So Alfred E. Newman thought we were crazy. We were going to use gemcitabine or fluorouracil in an adjuvant setting, and indeed, he was wrong, because in fact, we could improve the overall survival, median overall survival, for our patients who are operated on by about 25%. And when we tried gemcitabine, we got about the same 25%. So we're a little better than we were, but we're pretty weak. And the reason is that these tumors spread very early. They microscopically spread, and by the time we get to the patient, frequently the tumor has already taken hold in the liver, even if we can't see it, or in the peritoneal cavity. Radiation has played a role, and I'm not going to belabor this particular treatment. And basically, the SPAC, the people in Europe are sort of ahead of us. They've looked at this at 5-fluorouracil and gemcitabine, the two major drugs that we use, and found that they're about the same. So you can get fluorouracil or gemcitabine after the operation, and you can get radiation after the operation. And again, it's about, we improve the survival from surgery by about 25%. We need to go further. Obviously, this is not acceptable. And we have been testing neoadjuvant therapy in pancreas cancer. The definition of neoadjuvant therapy, and again, this shows how not too brilliant we oncologists are. Think of the adjuvant therapy. It's therapy administered prior instead of after the definitive therapy. And in GI malignancies, usually it's chemotherapy or chemoradiation therapy prior to surgery. Why? Well, if I meet a patient before Dr. Newman does, and we talk to the patient and say, we'd like to give you the chemotherapy, I can get systemic treatment into the treatment as quickly as possible, into the patient as quickly as possible. That gives me the fastest possible way of getting to the microscopic disease that we can't see. We'd like to make Dr. Newman's job and his surgical colleagues' job easier by downstaging the primary tumor. Sometimes we do that. And we'd like to affect sometimes the type of surgery that we do. Indeed, in pancreas cancer, we almost never do that. And it does help us to decide post-operative therapy, because if we have successful preoperative therapy, we generally will continue it in the post-operative setting. So we designed a trial at NYU. We okay? Oops. I'll hold on here for a second. This is the first time I've knocked somebody out of my seat. I'm very sorry. People have...
Oh my God, I didn't need to do that. I have back pain. It is. Oh my God, no.
Right. So you're going to admit that you didn't fall asleep while I was... Okay. All right.
No, maybe not. I was caught on the floor. I was trying to get it.
I'm sorry. I'm sorry.
I should have just left it.
It's a friendly audience. Don't worry.
I'm sorry.
So we designed the trial, and we designed the trial with gemcitabine and nab-paclitaxel, and I want to talk to you about that for a second. My dot is blue. Dr. Newman's dot was red. We designed the trial for patients who are resectable. And these patients have disease that Dr. Newman, I believe, can cure sometimes, but we think we can do better if we can give them chemotherapy and then what we call SBRT, stereotactic body radiation therapy. And we also designed the trial for patients that are borderline resectable, the more difficult patients, in the hope that, again, we can shrink the tumor. And again, these are patients, as I tell Dr. Newman every day, we practically share an office. I'm not real interested in making his life easier. I am interested in killing cancer cells. And if I don't shrink the tumor, it doesn't bother me as much as wanting to kill the cancer where I can't see it, because that's the goal of neoadjuvant therapy. Dr. Newman thinks it's to make his life easier, but that's not entirely correct. So we designed this trial, and the way we designed it, and the reason we designed it, was that we used research done at New York University by our dean, Dr. Barsaghi, when she and I were a lot younger, 30 years ago. And she found that certain kinds of cells, especially pancreas cells, have a way of bringing fluid into them, stealing nutrients, literally stealing them from normal tissue. And her research 30 years ago was then developed, and it takes a long time to do this research, almost 28 years later, by Kaz Camiso, who was one of the postdocs in her lab. And what Kaz and Dr. Barsaghi showed was that This process called macropinocytosis brings proteins, brings albumin into the pancreas cancer cells, again, stealing nutrients. Well, it's fascinating because Dr. Barsaghi and Dr. Camiso had never heard of nab-paclitaxel. Nab-paclitaxel attaches albumin to a drug. And we decided, as did my friend Dr. Von Hoff, that nab-paclitaxel might be the ideal drug to attack pancreas cancer. And that's how we developed our trial, and we were funded for about $2 million to do this trial, and it's ongoing as I speak. So it is an example of collaborations done in basic science, surgery, medical oncology, and GI medicine at this university. And this is what macropinocytosis is all about. It's an endocytic process by which extracellular fluid comes into cells via heterogeneous vesicles known as macropinosomes. And we think that the KRAS mutation actually uses macropinocytosis. So tumors that have KRAS mutated actually drag nutrients away from the body that needs it and into the tumor. So we want to fight that by putting the chemotherapy into albumin. Is that sort of clear? A few shakes. Okay, thanks. So this is where we called it KRAS-induced membrane ruffling from 30 years ago meets the old man in the clinic, and it's been a fun collaboration. So where are we going, and how can we do better? Well, I don't think there's anyone in this room that hasn't heard of immunotherapy. It's absolutely transformed the field of medical oncology and immunology, quite frankly, in the last 5 years in a way that in the way it's something I've never seen before, and I don't think anyone has ever seen this before. So we in the pancreas business want to get into this. The problem is that pancreas cancer, in contrast to melanoma and renal cell carcinoma, is not intrinsically immunogenic, and thus it's really important to make the tumor, to talk the tumor into being immunogenic. And how does one do that? Well, T cells invade these tumors, and T cells can have anti-tumor activity. Certain tumors, certain T cells, called high cytotoxic T cells, such as CD8 cells, actually leads to a better outcome in patients with pancreas cancer. So if I can bring these cells into the patient, they will have a better outcome. And unfortunately, more unfortunately, there are regulatory cells, which is a lousy word, and it's a great word to keep our immune systems going, but it's a terrible word in cancer, because there are regulatory cells that tumors tend to bring in, and they keep the tumor from being surrounded by the cytotoxic immune cells, and that's bad. So there are forces in the immune system and more that help us fight the tumor, and unfortunately in pancreas cancer, these regulatory cells take over. I won't bother you with the PD-1 pathway, but I will tell you that, again, when I got here, this woman, who's now an enemy of mine at Cornell, used to be my best friend when we were at USC and NYU, but she's switched over. She's up the street. Sylvia Fermenti and her group decided that radiation therapy could be looked at as a vaccine. And the reason why was that she and others published that neoantigens, things that tumors can see, are generated by cancer genetic instability, and that radiation can target tumor. Radiation targeted to the tumor can release these neoantigens and present them to the immune system and make the immune system more effective. And this explains why people like myself, every so often we would see a patient who get radiation to one spot in the lung, but the rest of the lung tumors went away. And the way Sylvia and her colleagues explained it was that we were causing a great immunologic rush, and the patients were responding. So we have developed a new study for patients that can't be operated on, using radiation as an immune primer, and using the classic, what we call PD-1 inhibitors and CTLA-4 inhibitors with radiation. And that study was developed by my colleague, Dr. Wu, and is now ongoing as well. When I gave this talk, which I think I did last year, when I gave this talk last year, the two protocols and trials that I've mentioned were not up and running, and they are now. And it's really, it's a great pleasure to be able to say that we are doing this research as I'm speaking. So this is a slide of what this study, what Dr. Wu's study is about, but I won't bore you with it. It's pretty straightforward. We give the radiation, and then we give the PD-1 inhibitor, and we hope that the radiation enhances the PD-1 inhibitor. So research is being done all over the place in this university and all over the world in pancreas cancer. It is a dastardly disease. It requires a village, if you will. It requires a university, if you will. It requires surgeons who are very forward-thinking. It requires medical oncologists who are going to work with surgeons. And it requires research from Dr. An, because I do believe that she is correct, that the only way we're going to eradicate this tumor is to find a way to prevent it, whether it's through bacteria or through other means, but prevention is going to be the key. And I wish that I live long enough to be able to see that come to fruition. So I'd like to thank you for suffering through this last talk, and I'm sure we'll all be glad to answer any questions.